Good morning, everyone. Today we are going to learn about twin block, the mechanism of twin block, the functional therapy. This was prescribed by William J. Clark. As you can see here, twin blocks are simple bite blocks with occlusally inclined planes. As you can see here, there is upper and lower arches with two bite planes, that is two inclined planes in the both upper and lower arches. The first twin block appliance was fitted on 7 September 1977 by William Clark. So this was the person who introduced this twin block appliances in 1977. Now moving on to the design of the twin block, how we can design the twin block. Occlusal inclined planes are there. The occlusal inclined plane is the fundamental functional mechanism of dentition. Cuspal inclined planes they play an important role in determining the relationship of the teeth, and as well as if the midline occludes in a distal relationship to the maxilla, that is in cases of class 2, the occlusal forces acting on the mandible in normal function have a distal component force that is unfavorable to normal forward mandibular development. So moving on to the wire components, you can see delta class as well as ball and class. These are the two components or wire components in cases of twin block appliances. Delta class, as you can see here in this picture, which is designed by Clark, there are retentive loops that are shaped as a closed triangle or a circle, as you can see in this picture, and this gives excellent retention on lower premolars. Next one is ball and clasp. Ball and clasp, there is a ball kind of end in the clasp. So they are routinely placed medial to lower canines and in upper premolar or deciduous molar region for interdental retention from the adjacent teeth. So these are the wire components. Twin blocks are constructed in a protrusive bite that is effectively modifies the occlusal inclined planes by means of bite block. So most probably whenever we place twin block, which is ideally recommended in cases of class 2 malocclusion. So class 2 malocclusion is distally occlusion, that is distal occlusion. So the teeth, we are moving the bite in a protrusive bite, which effectively modifies the occlusal inclined planes and becomes class 1 relationship. So class 2 to class 1, we are moving, or growth modification we are trying to do to achieve class 2 to class 1 molar relation. So the inclined planes are mostly angled at 70 degrees to the occlusal plane, although the angulation may be reduced to 45 degrees if the patient fails to posture forward consistently. So the the mostly angulation will be 70 degrees. As you can see, there is blue and red colored bite blocks, which is angulated at 70 degrees. So that is the angulation we are talking about. Next, the bite blocks act as a guiding mechanism. As you can see in this GIF, there is guiding mechanism which is causing the mandible to be displaced downward and forward. So from the class 2 molar relation, it is going, or it is made to go to the class 1 molar relation, which is in downward and forward. And the unfavorable cuspal contacts of the distal occlusion, they are replaced by favorable proprioceptive contacts on the inclined planes of twin block to correct the malocclusion and to free the mandible from its locked distal functional position. So class 2 means it is locked in the distal functional position. I'll be showing a video now. You can see here. See, this is a class 2 malocclusion. This is a twin block appliance in this green. This has two components, upper part and lower part. Okay, if you need an expansion screw, you can have an expansion screw in the middle. That is a modification. If no, that will be basic twin block appliance. And now you're moving this, you're placing this appliance and which is guiding you to the forward mandibular position. You can activate the screw in that so that you get a better expansion also. If the expansion is required, if there is crowding or anything, you can use the expansion screws as a modification. In the second stage, you saw now that is the trimming of the bite planes are taken up and then the molars are supraerupted. So there is trimming of these molar bite planes which occludes the molars in proper relationship, and then this is carried out with the phase 2 treatment option, that is FAT, that is fixed orthodontic treatment. So where the final alignment will be done properly. Now, when we are considering the fabrication of this twin block appliance, before we fabricate, we need to register the bite. Okay, so this is explained by Woodside in 1977. Mandible should be positioned protruded approximately 3 mm distal to the most protrusive position that the patient can achieve. So it is made to bring it forward. The mandible is made to bring forward, and vertically the bite is registered within the limit of the freeway space. Woodside TG in 1977, the activator in Grabber TM Newman B editors. This is the article which gave this gave the data about these things. Now, design and management of twin blocks. The article says about the inter-incisor clearance, which is of about 2 mm. That is inter-incisor. In between the incisor, there should be 2 mm clearance. In first premolar region, there should be 5 to 6 mm clearance, and in molar region, there should be again 1 to 2 mm clearance. So this should be the thickness of the bite. As you can see here, wax bite we are creating. So the thickness of the bite blocks are explained in the previous slide. Now, how the response is obtained with the twin block appliance or twin block treatment, or how the response is activated in the myofunctional system, that is the muscular as well as the functional, skeletal as well as the deep system, to change or to make the growth modification changes. When the mandible postures downward and forward, there is an area of immense cellular activity above and behind the condyle, condyle region, which is referred to as tension zone. So this area is quickly invaded by proliferating blood vessels and connective tissues. So this is how a twin block is actually functioning. New pattern of muscular behavior or muscle behavior is quickly established, whereby the patient finds it difficult and impossible to retract the mandible to its former prudent position. So this is known as pterygoid response. So we are bringing the mandible forward and making that position as a fixed position, so that all the changes related to the muscular as well as skeletal system is obtained according to or based on that position. So this pterygoid response is created. The muscles are the prime movers in the growth, followed by bone remodeling as a secondary response. So hence the muscle function must be altered over a sufficient period of time to allow adaptive bone remodeling or the changes in the bone remodeling to occur, and in order to reposition the condyle in the glenoid fossa. So this is what is happening behind the changes or behind the twin block therapy. Skeletal changes in twin block therapy are forward growth positioning or repositioning of the mandible, which is seen after the twin block therapy, as well as increase in SNB. As you can see here, S, that is S, N, and B. This angulation is also increased. Now, dental changes as a result of twin block therapy will be overjet reduction. That is, in class 2 cases, what will you have? There will be overjet, retroclination of the upper incisors, proclination of the lower incisors, buccal segment correction occurred by distal movement of the upper molars, and lower molar eruption in anterior and superior direction. So these all changes also you can obtain with the twin block therapy. Now, moving on to the stages of twin block therapy. When we have a twin block, as I've already explained when I was talking about the material and the construction. Now there are 3 phases, that is active phase, support phase, and retention phase. Active phase is about 6 to 9 months time period, which where the appliance is used to achieve correction of sagittal jaw position, that is the mandibular anterior position. After correction of the vertical discrepancy is corrected by selectively trimming the posterior bite blocks. So this is in the active phase. So after this is obtained, we are starting with the trimming procedure. So this active phase aims to achieve the correction of class 1 occlusion and control of the vertical dimension by 3-point contact with the incisors and molars. At this stage, the overjet, overbite, and sagittal relationship will be fully corrected. So active phase, you should obtain this overjet, overbite, and sagittal relationship corrections. As you can see here, this is the changes what we have explained here. This occlusion is changed to this, then trimming is started. As we trim the bite plane, the molars try to supraerupt and occlude in a different position. We are leaving a thin strand, that is thin anterior portion of the upper bite plane, so that the molars take changes, and this this angulation remains there itself. Next one is the support phase. In the support phase, once we obtain this molar relation, that is anterior and molar relation is obtained, this is to maintain the corrected relationship of the incisors until the buccal relationship is fully interdigitated. That is, incisor relationship is there, that we are maintaining to completely stabilize the molar relationship. So to achieve this objective, an upper removable appliance is fitted with an anterior inclined plane with labial bore to engage the lower incisors and canines. This is for the period of 4 to 6 months. This is the anterior inclined plane where you are correcting this incisor relationship also. Last phase is the retentive phase. In this retentive phase, this is the largest or the longest duration phase, which is retention. That is, whatever changes we achieve, the bone remodeling and all the stabilization changes need to be like stable, or it should maintain, or it should fix there itself for a period of 9 months minimum, so that that remains there. So the treatment is followed by retention with upper anterior inclined plane appliance. Appliance wear is reduced to night time, and only when the occlusion is fully established. Okay, so this is the phase where we are not having much pressure changes, but whatever we achieved, we are trying to stabilize or retain there. So that is called as retentive phase. And then later on, this is followed by any minor tooth movements and alignments, which is by the fixed appliance therapy for final alignment. So this is how the twin block therapy is done. Now, quickly we see on to the modifications of twin block appliance. I'll not detail left about these appliances. There is modification in class 2 division 2 malocclusion, where addition of the sagittal screw to advance the upper anterior teeth is given, or addition of springs lingual to upper incisors can be given. Incorporation of the lip pads to reduce hypermentalized action and relieve lower incisor from abnormal muscle force. So most of the cases you see puckering in class 2 cases. So in cases of those things, you can give lip pads. In class 3 malocclusion, where reverse twin block can also be given. So this is the mechanism how you give the reverse twin block. All these things will be reversed. Control of vertical dimension by sequentially adjusting thickness of bite plates to control the eruption. And in anterior open bite and vertical growth pattern cases, posterior bite blocks remain unreduced. Okay, so whenever you have anterior open bite or vertical growth pattern patients, you do not touch the posterior bite blocks. They remain unreduced and intact throughout the procedure, leaving anterior teeth to freely erupt. So these are the treatment options. If you have a retrographic mandible, you go for twin block appliance, upper incisor proclination, active labial bow, and twin block appliance. Treatment plan. So this is about the treatment options where you have twin block appliance, whether you should give the twin block appliance or no. Okay, so this is a complete packed knowledge about the treatment of twin block therapy, treatment using the twin block therapy. I hope everyone understood a bit. Thank you so much.